Respected physicians and dear participants, welcome you all to today's session on chronic obstructive pulmonary disease. It's our second part today. It's organized by BD Physicians Facebook group and sponsored by Escape Pharmaceuticals Limited. Our speaker is one of the finest internists of this country, Professor H.A.M. Nazmul Ahsan. Professor Nazmul Ahsan sir is now working as a professor of medicine, Popular Medical College, Dhaka. Sir was ex-departmental head, Department of Medicine, Dhaka Medical College. Sir was ex-president of Bangladesh Society of Medicine, and now Sir is governor, ACP chapter, Bangladesh. And we are fortunate enough that today we have with us one of the giant figure of pulmonology of this subcontinent and also a very renowned pulmonologist of the world, Professor DJ Christopher sir. Welcome, sir. Professor DJ Christopher sir is now working as Professor, Department of Pulmonary Medicine, Christian Medical College, Vellore, India, which is one of the finest institute for medical science in India. Sir is now also working as President, Indian Chess Society. Sir will chair this session. Now I am offering Professor DJ Christopher, sir, to start the session.
Thank you, Dr. Ahsan. Thank you for the nice words of introduction and for the welcome. I'm very pleased to be with you and greetings from my institution, Christian Medical College, Vellore, as well as my country, India. So we had a very good first session on COPD. That was on the occasion of the World COPD Day. Today, I think we are continuing in the same topic, but looking at more practical aspects with regard to diagnosis, management, and other things that you may be very keen to hear about. And to bring all this to us is Professor Ahsan. I mean, we are very privileged to have him share this with us. So without any more ado, I want to invite Professor to start his lecture.
Good evening, everybody. Thank you, Professor DJ Christopher and Dr. Ahsan, for your introductory complimentary words. And this is definitely an honor for me to present this topic. COPD is a huge topic, undoubtedly. That's why it has been divided in two parts. First part was mainly clinical on symptoms, signs, and differential diagnosis. And today we will be mostly concentrate on investigation and management. And I am happy Professor DJ Christopher, who is a renowned pulmonologist, and he is at this platform, and he will contribute with his knowledge and experience in this issue. Now I want to start my presentation. I have mentioned that today we will mainly concentrate on investigation and treatment, but just for recapitulation, we will continue with some slides regarding clinical aspects. Chronic obstructive is a common and preventable and treatable disease. And there are a lot of risk factors. Out of them, tobacco smoking is at the topmost level. Next to that, there are different types of pollutions, indoor pollutions and outdoor pollutions. So there are two phenotypes of COPD. Sometimes we say chronic bronchitis, sometimes we say emphysema, and sometimes we put them under the headline of COPD. Why we say separately chronic bronchitis, emphysema, and why is a COPD. Patients typically presents with combination of symptoms and signs of bronchitis. Sometimes it is possible to differentiate which patients are classically chronic bronchitis, which are emphysema, and sometimes it is difficult. Most important three symptoms are cough, respiratory distress, and wheeze. This cough is initially in smokers is dry, but after that it becomes productive, and is usually mucoid sputum. Sometimes it becomes infected, and that time it becomes yellow. Some patients of this chronic bronchitis ultimately develops respiratory distress, and the other group of patients starts with respiratory distress and it continues. Sometimes wheezing and bronchi, this is also present in some patients. That's why some patients are confused with chronic forms of or cough variants of bronchial asthma. So when we examine the patients, particularly in advanced cases of chronic bronchitis, emphysema, sometimes from the posture of the patient at bed, sometimes it is possible to diagnose that this is a patient of emphysema with respiratory failure. Sometimes they are polycythemic with plethoric features. Sometimes conjunctiva is red, and sometimes there is cyanosis, and chest is there is indrawing of supraclavicular, supraesternal recession, barrel chest, and sometimes there may be flapping tremor. So a lot of clinical signs on general examination, cardiovascular system, and respiratory system we get in these patients. So we define chronic bronchitis when there is a persistent productive cough for more than, so this is a clinical definition, persisting for 2 consecutive years. Emphysema, on the other hand, these patients starts with respiratory distress and progressively it continues. So sometimes this is, if we should try to differentiate whether this patient started with chronic bronchitis. Chronic cough is the main symptoms in case of chronic bronchitis, but emphysema in these patients starts with respiratory distress. In chronic bronchitis, this patient usually develops symptoms after 40 years. Smoking is the most important risk factor, and cough and sputum, these are the main important features. And cyanosis, the patient becomes cyanosed, but in case of emphysema patients, this becomes plethoric, and they usually thin emaciated. In case of chronic bronchitis patient, they develop cor pulmonale, edematous, cyanosed. So emphysema, they sometimes develop pneumothorax. So these are the differential points. So we say sometimes chronic, but they are obese. In case of emphysema, they are thin emaciated. These patients are cyanosed, blotted. That's why they are sometimes called as blue bloaters. And cor pulmonale, respiratory failure, these are important complications in case of chronic bronchitis, but in case of emphysema, they sometimes develop pneumothorax, and these are emaciated. These are the risk factors, and we have to differentiate these COPD patients from asthma patients. COPD usually starts after the age of 40 years, but asthma, they may develop from early childhood, even during infancy. So smoking is usually related with COPD, and it progresses with symptoms. History of allergen is present in patients of asthma and sometimes other allergic diseases like urticaria, allergic rhinitis, and these may be there may be family history of asthma in patients of asthma. So disease course is sometimes stable with sometimes with exacerbation, but in case of COPD, it is a progressive worsening disease. Spirometry, this is very important differentiation to differentiate. So these are the sum of the differential points in case of for clinicians. Now we will start with investigations. We do investigations to confirm our diagnosis, to exclude our differentials, since in case of when a patient presents with chronic cough for prolonged period, we consider bronchial as cough variant asthma. We have to consider tuberculosis, sometimes in case of malignancy, interstitial lung disease, bronchiectasis. So depending on the presentations, these are we have to consider some other clinical diagnosis. Hemoptysis is usually uncommon in patients of the COPD patients. We have to identify any comorbidities. Initial assessment regarding severity of the disease is very important, and we have to assess the prognosis of the disease whether the patient has got associated complications or the history of exertion. So these are very important, and for investigations we are do some these investigations for different purpose. So lung function tests, particularly spirometry, very important. Other chest X-ray, HRCT, other lung volumes and capacity, diffusing capacity, this is important. Oximetry and arterial blood gas analysis is sometimes required in case of acute exacerbation, and different types of exercise tests are there to assess the physical assessment for assessment of physical activity. So these are the investigations we do for different purposes. These simple investigations, we have to start hemoglobin, sputum, ECG, echo. These are all for different reasons. So spirometry, for when a patient is present with cough, sputum, wheeze, with risk factors, spirometry is a very important investigation. And the formal diagnosis is made with COPD after clinical diagnosis, when forced expiratory volume in 1 second is divided by force value is less than 70%. This is a very important diagnostic tool for diagnosing of this obstructive diseases. So spirometry is the most reproducible and objective form. And last day, someone asked one question. So this is a clinical diagnosis and is to be started with spirometry. Its sensitivity and specificity is also very high. Sensitivity is thought to be more than 90%, and specificity is around 84%. So when we start with the inspiration followed by a deep expiration, forced vital capacity, this is forced vital capacity. When we, during the first second, usually 4 liters of air is exhaled. And so if the vital capacity is 5, so 4 by 5, so obstructive lung disease, the spirometric pattern, this is the spirometric pattern. This green line is normal. So in case of obstructive disease, initially during first second, you see this is obstructive lung disease pattern. But in case of restrictive lung disease, especially when there is fibrosis, interstitial lung disease, initially there is increase during FEV1 is increased, but there is the rest part is this type of plateau. So both FEV1 and FEVC, the ratio, although both less, as this is not more than this is more than 0.7. So this is one of the important investigations, we can say, or tool. So Global Initiative for Chronic Obstructive Pulmonary Disease, GOLD, or American Thoracic Society, different organizations, they classify in different ways. This is one way of classifying or stratifying these patients into mild, moderate, severe, and very severe, depending on this FEV1. When it is more than 80% or more, it is stage 1 or mild, 50 to 79%, 30 to 49%, or less than 30%. This is called severe, very severe forms. Other forms of lung volumes, diffusing capacity, these are also sometimes very helpful. in assessing, because air trapping and hyperinflation occurs due to obstruction of airways. So this is also, and ultimately there is emphysema formation, and for that diffusing capacity we can. So this is one of the normal pattern. So volume curve. So this is usually we can see types of flow volume curves in case of normal, and in case of COPD, the FEV1. So this is shifted to on the left side, but in case of asthma, you see this is a concavity, pre-bronchial bronchodilator, and after bronchodilation, it also shifts to the right. So this is one of the patterns. These are other also patterns in case of emphysema and restrictive lung diseases. So chest in any form of respiratory disease, simple chest X-ray, particularly in this region, we do a chest X-ray for defined reasons. When a patient presents with prolonged cough, we have to think of pulmonary tuberculosis. So simple bronchiectasis, bronchial carcinoma. So simple in chest X-ray is very important for any differentiating from other different. But in case of COPD also, in case of chronic bronchitis, chest X-ray is mostly normal. There may be other comorbidities also, but in long-standing cases, sometimes right ventricular enlargement occurs, pulmonary conus becomes full due to pulmonary hypertension. But in case of emphysema, we get a lot of changes. So chest X-ray is very important, at least in our countries. In case of emphysema, we get low flat diaphragm and tubular mediastinum. Intercostal spaces becomes widened, and pruning of the blood vessels. Sometimes there may be multiple bulla formation, pneumothorax. So chest X-ray is very. This is one example. The X-ray is not that much good. So this is hypertranslucency, and there is retrosternal space is also increased, and ultimately there is anteroposterior diameter is increased, leading to barrel chest in case of emphysema. So this is another example. So HRCT is more helpful in diagnosing emphysema. So HRCT we do in case of bronchiectasis, interstitial lung disease. But if we think of emphysema, we can do HRCT just. Oxygen level, we do pulse oximetry. Nowadays, in case of COVID patients, we frequently ask the patients to keep pulse oximeter. So this pulse oximeter is very important for assessing oxygen level in patients. And sometimes arterial blood gas analysis is also required. Different type of physical activity tests are there. One popular is 6 minutes walking test. There are other endorsed paced shuttle walk test. This is also one is done. Distance walking in 6 minutes is a good predictor of all-cause and respiratory mortality in patients of moderate COPD. So this is physical activity to assess. It is also done. And in case of bird index, we know that FEV1, distance walking 6 minutes, modified medical research council dyspnea scale, body mass index. These are taken into account to what is the points in case of body index. Different types of echo, these are sometimes done in patients when there is right ventricular enlargement, or there may be associated, since the patients are smokers above the age of 40 years, whether he has got any ischemic heart disease or any other comorbidities. So these are echocardiography sometimes may be helpful. In case of patients with emphysema, when the patients are less than 40 years, when there is a family history, so in this, there is no smoking history. In these patients, sometimes alpha-1 antitrypsin levels sometimes can be done as evaluated. In a patient with cough, with the sputum examination is very important. at least in our country. So in case of chronic bronchitis, quality and quantity of sputum is to be asked to the patient, and this is very important for clinician. And increase in quantity of sputum production is often a sign of acute exacerbation. So different types of organisms may include, can be cultured during exacerbation, but importance are Streptococcus pneumoniae and Haemophilus influenzae. These are the very important different illness. Serum electrolyte, sometimes sodium retention occurs and sometimes potassium becomes less due to the use of diuretics and other mechanisms. Other tests, CBC, PCB is usually more due to secondary polycythemia count. These are also sometimes leukocytosis and acute exacerbation. And so different investigations we can do. In different diseases, sometimes we look for some biomarkers, particularly to see the pathogenic process and to ascertain the pharmacological response to treatment, like CRP or procalcitonin. Eosinophil count is sometimes done. So that scientists are looking for biomarkers in case of COPD. Now we will discuss something regarding management of COPD. The management strategy for stable COPD should be predominantly based on individualized assessment of symptoms and risk factors. All individuals who smoke should be strongly encouraged and supported to quit smoking. The main treatment goals are for reduction of symptoms and to reduce the future risk of exacerbation. Management strategies can be divided into pharmacological and non-pharmacological interventions. I have tried to go through some guidelines like GOLD guidelines and American Physicians Guidelines, American College of Physicians, chest physicians. There are Canadian guidelines, European, a lot of guidelines are there. But more or less, it is similar. We have in our country one is national guideline for asthma, bronchiolitis, and COPD also. So in case of the stable COPD patients, most important is diagnosis. After clinical diagnosis and confirmation, initial assessment is to be done, and then initial management is to be given, followed by review and ultimately adjustment of doses. These COPD patients initially is to be stratified depending on symptoms, history of exacerbations, exposure to risk factors and comorbidities, and spirometry in mild, moderate, severe, and very severe, as I have already mentioned. Other assessment tools also help in stratifying. One of them is Modified Medical Research Council dyspnea scale. They classify, stratify into 5 grades depending on severity of dyspnea. Particularly, the patient becomes breathless when do severe exercise, strenuous exercise. So grade 1 when he starts walking in level uphill, and this way. And stage 3 when it becomes he has to stop after 100 meters of walking. And grade 4 is he becomes breathless when he starts dressing or undressing. So this is one way of this. This COPD assessment tool, this is also done in case of, there are 8 questionnaires given to the patients. It can be given to primary physicians or even primary health workers. Even patients, they can fill up with it. There's 1 to 5 scales, so there are 40 scores. It may start from 0 to 40. So this is one way of assessing the severity of patients. Ultimately, all of them we can categorize into this way: the patient symptoms, spirometry, and the FEV1. This is GOLD 1, 2, 3, 4. Depending on exacerbations. So A and B, when there is no history of exacerbations, and C and D, these are the severe forms. So in case of A, B, this modified the Medical Research Council grade is 0 to 1 and CAT is less than 10. But in C and D group, you see this is more than 10. So depending on severity, we have to classify in this way. So non-pharmacological approaches is very important in managing patients of COPD. The important non-pharmacological aspects are smoking cessation, reducing exposure to noxious substances, vaccination. Others are nutrition, education of the patients, treatment of hypoxia, palliative care, etc. So non-pharmacological treatment, particularly smoking cessation, physical activity, and vaccination. This is important, all A, B, C, D grades, all categories. Smoking cessation is very important, I have said repeatedly. One has to document an up-to-date smoking history, including 5 years smoke. At every opportunity, advise and encourage every patient with COPD who is still smoking to stop and offer them to stop cessation of smoking. Vaccination is also very important in these patients. Influenza vaccination, it is to be given yearly, particularly at the end of October. In our region, from November, our winter starts. So at the beginning of fall, this influenza vaccination is to be given yearly. And there are two types of pneumococcal vaccine. And one is conjugate vaccine and is polysaccharide vaccine. So this in our country, around 48 million doses has been distributed since 2015 to cover the extended immunization program. So Streptococcus pneumoniae, this is a very common organism which can cause pneumonia, acute otitis media, and meningitis. So to cover many children's, conjugate pneumococcal vaccine is given as a part of extended immunization program. But this polysaccharide vaccine is given in those patients with having some diseases like COPD or after pneumonia, after splenectomy, and those patients diabetic, those patients are patients with cirrhosis, malignancy patients. But after age of 65 years old, this patient should be given. So to prevent pneumonia, at least 1 in 5 years it can be given. So vaccination is one of the important non-pharmacological aspects which prevents pneumonia in these patients. So goal of treatment is to reduce symptoms and to the risk of acute exacerbations. These are the main two goals in managing patients with COPD. Pharmacological treatments, oral and inhaled medications are used for patients with stable disease. Most medications are used to direct the following categories, that is potentially reversible causes of airflow. So to combat that, this treatment is given. A lot of drugs are there. Particularly bronchodilators are very important in managing patients of COPD. But in patients of asthma, steroid inhaler is very important. So to differentiate these patients of COPD from patients of asthma, this is very important for management purpose. So bronchodilator is the main medication which is given in patients of COPD. But in case of patients with asthma, inhaled corticosteroids is the most important medical medicine. So there are different types of bronchodilators, short-acting bronchodilators, short-acting bronchodilators and short-acting antimuscarinic agents, long-acting LABA, and long-acting antimuscarinic. So LABA, these are particularly salmeterol, indecterol. These are very important nowadays. And in case of LAMA, glycopyrronium, this is very important. There are some LABA-LAMA combination I will talk later on. In some patients, sometimes in addition to bronchodilators, sometimes inhaled corticosteroids may have to be given. So we have mentioned that initial assessment, we do group and stratify these patients into 4 groups: Group A, Group B, Group C, Group D. So rescue short-acting bronchodilators should be prescribed to an patients for immediate symptom relief. So Group A patients, those who have either 0 or up to 1 exacerbation that did not require hospital admission with modified medical research council category 0 to 1 and CAT less than 10. So these patients, this Group A patients, all patients should be offered bronchodilators treatment based on its effect on breathlessness. This can be either a short or a long-acting bronchodilator. This should be continuity benefit is documented. These are the Group B patients. Initial therapy should consist of a long-acting bronchodilator. Long-acting inhaled bronchodilator are superior to short-acting bronchodilator taken as needed. In the individual, the choice should be depend on the patient's symptoms and patient's choice. In case of C groups, includes those patients having history of more than 2 exacerbations that did not require hospital admission, or more than 1 exacerbation that require hospital admission. So initial therapy should consist of a single long-acting bronchodilator. It has, in some studies, it has been found that LAMA is superior to LABA. Group D, this is the severest forms of COPD patients. So in this patient, there is more than 2 exacerbations. So exacerbation in a patient of COPD is very important. It has been said in some books also, one exacerbation can be considered as a patient of acute MI developing in a patient of stable angina. So we consider acute MI as a serious condition. Like that, acute exacerbation in a patient of COPD is considered as so important that in a patient, acute exacerbation is in a patient of stable COPD, like acute MI in a patient of stable angina. So that's why stable acute exacerbation is considered in this risk assessment. In general, therapy can be started as a long bronchodilator, but sometimes in a short course, steroid can be given in these patients. So after initial pharmacological treatment, review, assessment, and adjustment of dose, this is to be done. So this is one algorithm in patients of dyspnea or acute exacerbation. So these bronchodilators can be in a patient on either alone or in combination. And in case of acute exacerbation also, this is a algorithm. The response of treatment, after response, there without improvement, there may be escalation, or with improvement, there may be de-escalation can be done. So I will show now again, I have made it long just to make it simplify and to repeat. So there are short-acting bronchodilators like salbutamol and terbutaline, these are, and short-acting anti-acting muscarinic antagonists like ipratropium. So these are the short-acting bronchodilators. There are long-acting beta-2 agonists like salmeterol, and recently nowadays we are using Indecor. This is given in twice daily dose, and Indecor it is used as a once daily dose. So these are long-acting beta-2 agonists. There are long-acting anti-muscarinic antagonists like glycopyrronium or tiotropium. These are the long-acting anti-muscarinic drugs. There are some inhaled combination therapy in some patients. But there should be some indications where we can give. So there are combinations of short-acting bronchodilators and SAMA and combination of LABA and LAMA. So the indicatorol, glycopyrronium, this is in our country we have this formulation, and also this one also. So there are a lot of available formulations in our country also. Bangladesh, India, we are fortunate that in our people, our patients, they are getting a lot of drugs in our country, and these are reasonably cheap also in comparison to this medicine available in other Western countries. Salbutamol, these are short-acting drugs. A lot of salbutamol and ipratropium preparations are there. Simple ipratropium, sometimes inhaled steroid with salmeterol, and sometimes salmeterol, fluticasone, beclomethasone with formoterol, and all these preparations are available in our country. This indicatorol, this is most important recent, which is you can be given only one dose, and there are indicatorol glycopyrimidine. This is also available in our country. So this can be given in only once a dose. So combinations of LABA and corticosteroid, there are some preparations also. Triple combination, to my knowledge, it is not available in our country at this much, so far as I know. So LABA and LAMA should be offered to all patients, maybe given to patients having experimentally confirmed COPD. Patients do not have asthmatic features and remain breathless or have exacerbations despite having used or been offered treatment for tobacco dependence if they smoke, and optimize non-pharmacological management. So in this patient, this treatment can be offered. And these LABA and inhaled corticosteroids should be considered when they have spirometrically confirmed COPD and have asthmatic features or features suggestive of steroid response, and remain breathless or have exacerbation despite having used or been offered treatment for tobacco dependence. So in these patients only, inhaled corticosteroid can be offered. So this is triple therapy. This can be given in these patients. So these indications. So these different preparations, they have certain indications. So we can offer treatment these two different categories of patients. So that's why I've broken up the categories of drugs and different patients group. So if there are inhaled corticosteroids, this regular, we usually use this in asthma patients, but it is not used as first line or second line treatment in patients of COPD. Regular treatment with inhaled corticosteroids increases the risk of pneumonia. So there are a lot of other side effects, that's why it is not used. But in some, when there is history of severe exacerbation, more than 2 moderate exacerbations per year, or presence of concomitant asthma or eosinophil blood count is high. In these situations, we can offer oral corticosteroids is reserved. This is not usually given unlit in case of acute exacerbation. Antibiotics in older studies, prophylactic antibiotics, continuous use of antibiotics had no effect on therapy, but nowadays it has been found that azithromycin, when given 500 milligram twice per day for 1 year, azithromycin 50 milligram per day or 500 milligram 3 times per week, sometimes it prevents from exacerbation. So it can be given in ways, some mucolytics graphs sometimes may be helpful. Acute exacerbation is very important in patients managing with COPD. There are 3 types of acute exacerbation we can classify as mild, moderate, and severe. Severe acute exacerbation, in case of moderate, when there is hypoxemia and when it improves with the venturi marks, we can consider as moderate. But when it is not improving with these venturi marks, this oxygen, then it is called as severe. So oxygen therapy, bronchodilator, on a systemic short course steroid is given, and sometimes we also give antibiotics in some patients when there is suggestive of infections. In those patients, sometimes non-invasive mechanical ventilation is preferred. So these are additional management tools. So there are some patients with severe forms not improving with treatment. So severe dyspnea, when there is mental confusion, hypoxemia persists, and sometimes this patient may have to be referred to ICU. So respiratory failure is one of the important complications. Both type 1 and type 2 respiratory failure occurs. So in case of acute exacerbation of COPD, so this is the management. When we are do chest X-ray, sometimes there may be pneumonia or pneumothorax. If there is yellow sputum, we give antibiotic, and we do blood gas analysis. There may be type 1 respiratory failure, or there may be type 2 respiratory failure. So this is the oxygen therapy in patients. So this we need to know. Sometimes there may be chronic hypoxia in some patients. This is a crippling part of this disease. So long-term oxygen therapy, some person may have to continue for a long time. So cor pulmonary is another complications. This is very common in medicine ward. Some patients present with right-sided heart failure and cor pulmonary lesion. So there are drugs which are avoided in patients of cor pulmonaria. So rarely, sometimes some intervention or surgical intervention may have to be done. Pneumothorax is one of the good examples in patients with emphysema. End of life care is very important also. So I'm almost at the end part. So chronic COPD, this is a preventable and treatable disease. Most common respiratory symptom of dyspnea. Two phenotypes, one is chronic bronchitis, one is emphysema. Sometimes it's difficult to differentiate. Spirometry is one of the important tools in diagnosing. The smoking cessation is one of the important non-pharmacological part. Each pharmacological treatment regime should be individualized and guided by the severity of symptoms, risk of exacerbations, and categorization of severity assessment. Influenza vaccination is also very important in these patients. Influenza vaccination and pneumococcal vaccination, this is to be offered to these patients. Treatment need to be adjusted periodically, and escalation, de-escalation may have to be done. Thank you. I'm expressing my thanks to BD physician for requesting you to present this one. Very much.
Sir, thank you very much for your outstanding presentation. Sir, we have many questions. Now I will start with Dr. Saifullah Rajin. He got 6 questions. And I think all the question is very important. I will straight away go to our today's chairperson, Professor DJ Christopher sir, with the questions of Dr. Saifullah Rajin. His first question: how can we delay progression of COPD?
Okay. So I think Professor Ahsan nicely brought out the fact that one of the important aspects of COPD management is to ensure smoking cessation. There are very few things that can delay progress of COPD, and probably the most important is smoking cessation. So other than that, some people think that there's something called pulmonary rehabilitation, which is a comprehensive kind of a support, which includes physical exercise, which includes nutritional support, which includes various specific exercises to the respiratory system. So it is believed that these people may, that this also may slightly prolong survival. Unfortunately, all these exotic bronchodilators and all these things, they make a huge difference in quality of life and symptoms, but they do not extend survival. So that is unfortunately the sad reality. The only other thing that perhaps could extend life is in people who are hypoxic. Long-term oxygen treatment, giving oxygen at home, has also been shown to improve survival. So shall I share a slide?
Sure, sir.
I think I showed this the last time. Can you see the slide?
Yes, sir.
Okay. So this is a person who has never smoked. So this is 25 years of age, 50 years of age, 75 years of age. So if a person never smokes, after 25, slowly his lung function starts reducing gradually. And the reduction is very slow. It will probably never cause any symptom or hardship to that person. Now, this is a smoker. They have drop in lung function, but this is a precipitous drop, unlike the normal drop. Normal decline is slow, whereas this is a rapid drop. And so at some point in their life, they will reach a point of disability. They'll be short of breath. They cannot carry on normal work. That is this point. And beyond that, after some time, they may die. So that is this point. Now, if you stop smoking at this point, they have not got symptoms yet, but you stop smoking, then their survival, they get symptoms late, and then they also die late. Likewise, then they already are dyspneic. They come to you. So then you counsel them and make them stop smoking. Even though it is late stage, still their survival is increased. So the most important intervention to improve survival is smoking cessation. Sorry, it was a bit long, but it's an important point. Next.
Sir, his next question, sir, is there any role of long-term antibiotics in frequent exacerbation of COPD? If so, which will be the choice?
For select patients, people have tried macrolides. And among macrolides, the most used is azithromycin. So at a dose of, thrice weekly or something like that, if it is taken, then it is known to reduce infective exacerbations. It is even more effective in bronchiectasis, but it can be used in select patients with COPD, not everybody. It is the group of people, they have frequent exacerbations, and you have given all the other inhaled medication and supports, and still they still have exacerbations. Then you can try this.
Okay, sir. His next question, but which is asked by some other participants, sir, role and scope of roflumilast in COPD.
Okay, so roflumilast is useful for a small fraction of patients. I will share screen again. I will make this big. Okay. So this is a kind of a flow chart. Patients are divided into two categories: those that have predominantly dyspnea, those that have frequent exacerbations. And you treat them slightly differently. Both of them get bronchodilators, but there are slight variations in how you treat these groups. So in this group, those who have exacerbations, if they don't respond, if they have long-acting bronchodilator, the long-acting beta-2 agonist and long-acting muscarinic antagonist. So these two combinations, which the professor talked about in this lecture. So this is the ultimate combination of bronchodilator. If after that they are still symptomatic, you have to give them some more. So there are two ways you can give. If they have more than 100 eosinophils in peripheral blood, 100, so then you give inhaled corticosteroids in addition to the LAMA and LABA. So eosinophil is a marker of response to inhaled corticosteroids. I'm sure there are other questions coming on inhaled corticosteroids, so I will address that straight away. So inhaled corticosteroids is used in patients in whom two conditions. First, If the eosinophils is more than 300, you can use. Or if the eosinophil is only not more than 300, but only more than 100, but they have 2 or more moderate exacerbation or 1 hospitalization. So in these patients, inhaled corticosteroids can be used. Only in these patients. So when to use, not in everybody, but only in this group of patients. Let's come back to the point. So if they have less eosinophils, less than 100, what to do? They can't be given inhaled corticosteroids. In them, one of the options is roflumilast. So exacerbators who are not controlled on inhaled LABA-LAMA combination, and if the eosinophil is less than 100, so inhaled corticosteroids are not going to work. In them, you can try roflumilast.
Thank you, sir. Now I'm going back to Professor H.M. Nazmul Ahsan, sir. Sir, is there any role of montelukast or theophylline, doxyphylline in case of COPD? Because in our country, we usually practice, if we see any patient with breathlessness, we used to prescribe these drugs. So what's your opinion about this?
Montelukast is not going to help in these patients, but in theophylline, I have shown then it has some actions and it can help in some patients. So these are the drugs which can be given in some patients, but montelukast is not helpful in COPD patients.
So another question to you, sir. Indication of starting antibiotics in COPD.
Professor, she has mentioned that one is prophylactic antibiotic in those patients who are showing recurrent acute exacerbation. Periodic doses of macrolides like azithromycin or erythromycin. Azithromycin is given thrice weekly for 1 year. It can give benefit. But in case of acute exacerbation, sometimes if there is in fever or sputum is yellow, or if there is other markers of leukocytosis or procalcitonin, in that situation we usually give or sputum culture sometimes showing that is some acute exacerbation, some organisms like streptococcus pneumoniae and Haemophilus influenzae, these are the important organisms. So in those situations, antibiotic can give some help.
Thank you, sir. Now I'm going back to Professor DJ Christopher, sir. Sir, Dr. Saidur Rahman Himal has got lots of questions. I'm selecting 2 to 3 among them. Sir, first question, is carpulmonale is curable totally?
Carpulmonale is a kind of a pre-terminal or terminal complication of COPD. So why does carpulmonale develop? So basically, for the interest of, in the interest of the rest of the people, so this is right ventricular strain characterized by right ventricular right atrial hypertrophy or right heart failure. So that is called carpulmonale if it is due to chronic lung disease. So COPD therefore is one of those conditions that can lead to this change. Why does this happen? This is a response of the cardiovascular system to hypoxia. And so the hypoxia causes pulmonary vasoconstriction, and when the right ventricles pump against vasoconstricted passage, they hypertrophy and they dilate. So they are prone to right heart failure. And so since this happens when they are already hypoxic, and now in addition to hypoxia, they already now have heart strain and possibly heart failure, the chance of them living too long beyond that is not significant. So whether to reverse that, yes, with diuretics, with inhaled drugs, and with optimization of condition, you may pull them out of a right heart failure. But whether you can make them normal people and reverse all the changes, I don't think is possible.
Sir, his next question, when we make a decision to lobectomy or bulectomy?
No lobectomy. The COPD is a diffuse disease. Therefore, doing lobectomy is not going to work. Bulectomy, yes. So what is bulectomy? If some people have large air-filled balloon-like, kind of structures inside the lung. So what they do is, so this is the complication of emphysema. Emphysema is a dilatation, but as it gets more complicated, some of the parts of the lung can get inflated with no lung tissue, just air-filled kind of a pocket. The effect of that will be on the functioning of the normal lung. Since these are balloon-like structures, they will compress the normal lung and reduce their function. So if these bullae are large, in which case the effect on the lung will be more, there is a role for bulectomy, whereby the surgeons go and remove the bullae, or in the past they used to do what's called plication. Essentially, they will kind of compress this air-filled balloon or air-filled structure so that the rest of the lung can expand and function normally.
Thank you, sir. Last question from him. Is there any association between COPD and type 2 diabetes mellitus?
Not direct association, but these are common comorbidities. A lot of people who have COPD will be diabetic. They will have ischemic heart disease and so on. So these are common comorbidities of COPD patients, but we cannot say that they are related.
Thank you, sir. Now to Professor H.M. Nazmul Hassan, sir. So Dr. Mahmudul Hassan has a question. Sir, what is the difference between cough and sputum of COPD versus asthma or related disorder? Though you highlighted about this, till then, sir, if you say again.
I have tried to mention that cough and sputum, this is one important symptom in patients of chronic bronchitis. And in case of emphysema, these patients start with respiratory distress and it progresses. But respiratory distress is a terminal event in case of chronic asthma, but in case of chronic bronchitis. But in patients of bronchial asthma, usually they develop episodic breathlessness in most of the time. But there are some variants of asthma who have also, in addition to respiratory, they might have some cough. And some patients of asthma, they are called cough variant asthma. But in case of cough variant, usually sputum is, there is dry cough and the mucoid sputum. But in case of chronic bronchitis, sputum production is increased and sometimes CLS sputum. And cough and sputum, this is very characteristic in case of chronic bronchitis.
Thank you, sir. Now, again to Professor DJ Christopher, sir. So we have got total 6 questions from Dr. Aki. I shall ask 3 from them. So first question of her, sir, if someone feels shortness of breath a lot, but chest X-ray is clear, does this mean that his or her lungs are okay and COPD free?
COPD is not diagnosed by chest X-ray. If they are short of breath, then that can be due to multiple causes. COPD is one of them. Asthma is another. Interstitial lung disease is another. Then there are vascular causes like pulmonary embolism, where the lung will look quite normal, but there may be a thrombus or embolus sitting in their pulmonary arterial system. So you definitely cannot say on the basis of an X-ray that somebody does not have COPD. Spirometry is the gold standard test, and only if that is normal can we say that they are less likely to have COPD.
Thank you, sir. Our next question: is it okay to do a spirometry test while taking antibiotics or steroid, or there is a specific guideline?
Well, that question has a direct answer, and it has got a more complex answer as well. The direct answer is no. Antibiotic doesn't interfere with test. I think you asked steroids, is it? That also
Yes, sir.
doesn't interfere directly with the test. Okay. Now the question is, why are they on antibiotic and why are they on steroids? I assume you're talking about oral steroids. So most situations, I mean, we would normally give these drugs when someone has an exacerbation. So if they are taking these drugs for an exacerbation is a kind of a relative contraindication to do a spirometry. If you want to assess the lung function, it is better to wait for the exacerbation to clear and the lung to return to its normal. At least 1 month it will take after an exacerbation. Only after that, it is better to do a lung function test. But if they are on antibiotics or steroids, it means that they probably have an exacerbation, and therefore that's not a good time to take this spirometry test.
So last question from Mahar. So what is the role of flu vaccination in COPD patients?
Again, I think Professor talked about it. So flu is one of the agents that can cause an exacerbation of COPD. And it is one of the infections that we can possibly prevent. That's why we recommend vaccination of all patients for flu and also preferably for pneumococcus. So flu vaccine is a useful thing for COPD patients.
Thank you, sir. Now to Professor H.M. Nazmul Ahsan, sir. We'll continue this session for another 10 minutes. Sir, from Dr. Muhammad Saifullah, though both asthma and COPD are chronic inflammatory disease of airway, why asthma is reversible but COPD is irreversible?
In case of asthma, the pathophysiology of two diseases is different. In case of asthma, there is hyperresponsiveness of muscular coat of bronchial of respiratory passages. That's why there is episodic respiratory distress in case of bronchial asthma. But in case of chronic obstructive pulmonary disease, in response to chronic irritation, there is a chronic obstruction to the respiratory passage. And when this irritation or pollution or any noxious substance continues, there is progressive obstruction, it continues. So in case of asthma, it is a reversible one, but in case of COPD, this is an irreversible and progressive disease.
Thank you, sir. Now, there is a very important question from Dr. Jubair Chishti. It's for Professor DJ Christopher, sir. As it's COVID era, so his question is related with COVID. Sir, if COVID patient is, for COVID patient, will it be wise to give other pneumonia or influenza vaccine in same setting, acute stage?
So influenza is a viral infection and so is COVID. Now, normally influenza injection is not given when someone has an infection, any infection. So you wait for the infection to clear and then give the vaccine. Therefore, for COVID, the same thing holds. If they are doing well and they are high risk group, it's better to give them flu vaccine. But you don't give it when they have an infective exacerbation.
Thank you, sir. Sir, another question for you, though Nazmul sir highlighted about it. Sir, is there any investigation to differentiate between chronic bronchitis and emphysema?
Well, chronic bronchitis is a disease or a condition that is characterized by cough and sputum production. It's a clinical definition. So it is characterized by airway obstruction. So if you look at pathology, you're looking at thickened airways and obstructed airways. That is chronic bronchitis. Emphysema is again a pathologic definition. It's a pathologic definition. It is dilated, distended and dilated airways and alveoli, destroyed alveoli and dilated alveoli. So that's the definition of that. So if you really want to demonstrate these things, especially emphysema, CT scan is probably the best test. In lung function, people with emphysema are likely to have more severe obstruction. But that itself will not distinguish chronic bronchitis from emphysema, but CT scan may do.
Thank you, sir. Now we are at the almost at the end. We'll take another 2 or 3 questions and then we'll close the session. For last question to Professor H.M. Nazmul Ahsan, sir, from Dr. Mushfiq Raihan, sir. In COPD lung function test, airflow limitation is partly reversible sometimes, but why is that?
In case of COPD, I have mentioned that there are some groups of patients who have asthmatic features also, and there may be reversibility sometimes, and some portions of reversibility there may be, and though that's why there may be a history of reversibility, and sometimes their eosinophil count is found to be high. In these patients, sometimes this FEV1 sometimes may be reversible or improved. That's why in these patients, inhaled corticosteroid in addition to bronchodilators sometimes may be helpful. A small percentage group of patients.
Thank you, sir. Now, our last question is for today's chairperson, sir. Sir, from Dr. Noshin Tabassum, her question is, sir, is it judicious to label the patients with COPD whose symptoms improve with steroid as ACO, means asthma COPD overlap? Is there any variation in management of these patients? And another question from Sir Dr. Prottoy, if we prescribe azithromycin for 1 year, what will do after that?
Okay, asthma COPD overlap syndrome. So we know in practice that there are some people that have typical asthmatic symptoms, and there are some people with typical COPD symptoms. You don't have any doubt about the diagnosis. But there are some that have features of asthma as well as features of COPD. For example, people with heavy history of smoking and still show significant bronchodilator reversibility on spirometry test. So are they COPD or are they asthma? So these are the situations of overlap. That's why this asthma COPD overlap, earlier it was called asthma COPD overlap syndrome. Then they took off the syndrome and just called it asthma COPD overlap. So yes, there is an entity where people have features of both. And the only reason why we should distinguish this is that you would offer this group inhaled corticosteroids. If you had diagnosed only COPD, you will give predominantly bronchodilators. Only in a small fraction you will choose for inhaled corticosteroids. But anybody who you diagnose as ACO, you will give inhaled corticosteroids along with bronchodilators, invariably or always. So that is a difference between ACO and COPD, and that's why it's important to know that. The second question was?
Sir, what will we do after 1 year course of azithromycin?
Azithromycin. Okay. So, well, you give it for 6 months or you give it for 1 year, and if the patient is doing well and is benefiting, you may continue it for more time. But what you can do is you can try to withdraw, and if the patient has more infections, you can start that back again. So how long to continue, nobody knows. The studies that have been done are only 1 year and things like that. But what will happen in 3 years, what will happen in 5 years, we don't know. So my own take is that if with that drug, the patient is better, you can continue that judiciously.
Thank you, sir. Professor H.M. Nazmul Ahsan, sir, do you have any final comment or any take-home message for your students and your doctors?
Regarding this topic, I want to again say that whenever the patient presents with respiratory distress and cough, this is a common thinking that this is a case of asthma. But a good number of the patients are actually patients of COPD. Secondly, some patients of COPD, it is possible to differentiate a label as from patients of chronic bronchitis and a group as emphysema. But in certain groups, it is very difficult to differentiate. We are trying repeatedly, and also Professor Christopher has said, in case of patients with COPD, bronchodilator is the main drug, and non-pharmacological approaches, particularly smoking cessation, is very important, and vaccination is also very important. But in case of asthma patient, inhaled corticosteroid is very important medication. So these are the main messages I want to give, and I want to express again thanks to BD physician and Dr. Ahsan, and this is nice to see Professor Christopher in this platform. Nice to meet him. Thank you.
Thank you.
Thank you very much. And now I am inviting our today's chairperson, Professor B.J. Christopher, sir, to conclude the session.
Yeah, well, it has been a very interesting discussion. First, we had a very lucid lecture by Professor, and then we had a very interesting and vibrant session with a lot of questions. I'm sure if there's more time, you'll be asking a lot more questions and we can keep on going. But of course, all good things have to come to an end. So thank you for your patience. I hope it was beneficial to you, and I hope it helps you in your practice.
Thank you very much, sir.
Professor. Yeah.
And sir,
thank you.
Again, thank you, sir, for any special reason, because 22nd December is coming soon, and we are waiting for your presentation about interstitial lung disease. And sir, this is the month of December. This month is for Bijoy. Bijoy Divos, just we have celebrated, and India was a great partner of this independence. So, sir, thanks on behalf of us, and waiting for your presentation in December 22.
Thank you.